Good morning, everyone. I'm excited to welcome you to today's presentation. We'll be exploring a very important topic: ambiguous terms, high-risk abbreviations, and safer documentation patterns. The subtitle is Mind the Context: When Medical Prompts Goes Wrong. Today, we'll look at how language in medical documentation can sometimes lead to misunderstandings, and how we can improve our practices to ensure clarity and safety. Over the next few slides, I'll guide you through common pitfalls and best practices. Let's get started. So on this slide, we're diving into why ambiguity really matters in our work. Essentially, unclear language can lead to misunderstandings, errors, and even safety issues, especially in technical or complex settings. That's why having a practical template to minimize ambiguity is so important. It helps us communicate more clearly and effectively. We'll look at ambiguous terms and abbreviations, organized by category from A to K, to see how different types of language can cause confusion. Then, we'll explore some specialty-specific pitfalls, areas where ambiguity tends to creep in more often and can have serious consequences. Next, I'll walk you through a worked example, showing what things look like before and after applying these clarity-focused approaches. This will give you a concrete sense of how to implement these ideas in your own work. We'll also cover some implementation ideas, including notes relevant to the UK context, and key takeaways to keep in mind moving forward. Finally, you'll see the agenda for today's session, which will guide us through understanding and reducing ambiguity step by step. The overall goal here is to improve our communication, reduce errors, and ensure everyone is on the same page. Let's talk about why ambiguity in communication can be such a problem. Terse notes, abbreviations, and leaving out context often lead to misunderstandings. When information is too shorthand, it can be misread or misinterpreted. AI systems tend to default to the most common sense interpretation, but that's not always the one you intended. This can be particularly risky in high-stakes situations like handovers, emergency department triage, radiology reports, theater lists, and prescribing. In these cases, clarity is critical. To address this, we need to be specific by including details like the site, specialty, intent, units, and timing. And importantly, we should expand on the first use of any abbreviations or acronyms to make sure everyone's on the same page. Ultimately, understanding why ambiguity matters helps us improve safety, communication, and patient care. Let's break down the key points we see on this slide. First, the body site and laterality are important details. For example, distinguishing between the cervical spine and the cervical os, or noting whether a lesion is on the right or left side, helps us precisely identify the location of the issue. Next, patient context is crucial. This includes age, sex, and whether they are pregnant or postpartum, as these factors can influence diagnosis and management. We also need to consider the specialty or setting in which the assessment occurs, such as the emergency department, outpatient clinic, radiology department, or during surgery in the theater. Each setting has different implications for urgency and approach. Temporal information is another key element. For example, measuring troponin I levels over time, like 0.08 nanograms per liter rising at 3 hours, gives us insight into the progression of cardiac injury. When interpreting test results, it's important to specify the test name, the result, and how it compares to the reference range or the method used, as this frames the significance of the findings. Procedural intent is also part of the template. Whether the test or intervention aims to diagnose, confirm, or treat a specific condition, such as fracture reduction in orthopedics. Overall, this slide provides a practical template to avoid ambiguity, ensuring we gather all relevant details systematically. Remember, the goal here is to be thorough yet clear, connecting each point back to the bigger picture of accurate diagnosis and patient care. Let's take a look at some examples of polysemous anatomy and how directional terms can vary depending on the context. First, notice how the word cervical can mean different things. It's often used to refer to the neck or spine, but it can also mean the cervix, which is part of the reproductive system. Similarly, fundus can describe different structures depending on the organ, like the fundus of the uterus, the stomach, or even the eye. Moving on, the terms apex and base are used across various organs. Think of the apex of the heart, or the lung, or the base of the skull. These directional terms help us locate parts precisely. The cortex, meanwhile, appears in different contexts, like the cerebral cortex in the brain, the renal cortex in the kidney, or the adrenal cortex. Now, regarding the terms labial, dorsal, ventral, palmar, plantar, medial, and median, these are essential for describing positions on the body or organs. For example, dorsal and ventral describe back and belly sides, respectively, while palmar and plantar refer to the palm of the hand and sole of the foot. Lastly, when we talk about structures like septum, valve, sinus, antrum, canal, or hilum, it's crucial to specify the organ involved because these terms are used across different systems. Similarly, in bone imaging, identifying regions and noting whether a lesion is a cyst, nodule, mass, or other abnormality requires attention to both site and modality. Overall, understanding the polysemous nature of these terms and how directional terminology varies is key to accurate communication in anatomy and radiology. This helps us avoid confusion and ensures precise descriptions across different contexts. Let's take a closer look at some commonly confused terms in anatomy and terminology. First, we have ilium and ileum. These might sound similar, but the ilium refers to the last part of the small intestine, while the ileum is the broad, upper part of the pelvic bone. Next, perineal and perineal. Again, similar sounds, but the perineal relates to the fibula and lateral side of the leg, whereas the perineal refers to the area between the genitals and the anus. Moving on, ureter and urethra. These are both part of the urinary system, but the ureter carries urine from the kidney to the bladder, while the urethra is the tube that carries urine out of the body. Then, malleolus versus malleus. One is a bony prominence on the ankle, the other is a tiny bone in the middle ear important for hearing. Now let's look at some bones. Scaphoid in the wrist and navicular in the foot. Both are carpal and tarsal bones respectively, but they're in different locations and serve different functions. The trapezium and trapezoid are also wrist bones, close in name but distinct in position. Radial and radius, these are often confused, but the radial is an adjective relating to the radius bone, which itself is one of the two forearm bones. Then tarsal and carpal. Tarsals are bones of the foot, carpal bones are in the wrist. Moving to the pelvis, pubic versus pudendal. Both relate to the genital and pelvic regions, but the pubic is a bone, while pudendal refers to nerves and arteries in the area. Adductor and abductor muscles. Adduct muscles bring limbs toward the midline, while abduct muscles move limbs away from it. Varus and valgus. These terms describe angulation of joints, with varus meaning inward angulation and valgus outward. Pronation and supination, referring to hand and forearm movements, where pronation turns the palm downward and supination turns it upward. Anteversion and retroversion, these describe forward and backward tilting of parts, like the pelvis or uterus. Next, median and medial. These are directional terms, with median referring to the middle line and medial meaning closer to that midline. Saphenous and cephalic, both are superficial veins in the limbs, but they are on different sides. The saphenous is medial, the cephalic is lateral. Finally, we have the thoracic outlet and inlet, key anatomical regions at the top and bottom of the thoracic cavity. And a quick note on look-alike or sound-alike terms, LASA terms. These can easily cause confusion, so it's important to understand the subtle differences, especially in clinical practice. All of these examples highlight the importance of precise terminology in healthcare. Recognizing these similar-sounding or similar-looking terms helps us avoid errors and communicate more effectively. Let's take a closer look at some critical clinical terms that can often be confusing due to their multiple meanings. First, we have words like shock, stroke, seizure, and block. These can refer to different conditions depending on the context, so it's essential to understand their specific clinical implications. Next, we encounter positive and negative adjectives, which are often used to describe test results or patient states. For instance, A benign result usually indicates a non-threatening condition, but always consider the context to interpret it correctly. Moving on, terms like induction, reduction, fixation, and lysis are common in procedures or diagnoses. Induction might refer to starting a process, such as anesthesia, while reduction involves realigning a fracture. Fixation is about stabilizing tissues or bones, and lysis refers to breaking down cells or tissues, often in the context of treatment or pathology. When we see infiltrate or culture, we're usually talking about infectious processes. An infiltrate can be an abnormal substance in tissues, and cultures help identify causative organisms. The concept of a left shift is important too. It indicates an increased number of immature white blood cells, often signaling an infection or inflammation. Failure, of course, can refer to various clinical scenarios like organ failure or treatment failure, so always look at the context. Finally, it's crucial to recognize that some clinical words have different meanings depending on the situation. For example, shock might refer to a circulatory collapse or a sudden surprise, while block could mean a physical obstruction or a neurological interruption. Understanding these nuances helps us communicate and interpret findings accurately within the broader scope of patient care. Let's take a closer look at some of the abbreviations listed here. RA, AS, MS, Mr., AR, AI, PA, PE, CP, DC, SOB, PR, PT, and CVA. When we first introduce these abbreviations, it's important to fully expand on what they stand for so everyone understands exactly what we're referring to. Clear communication is essential, especially during handovers, so we want to avoid abbreviations that might cause confusion. For example, instead of just saying RA, we should say rheumatoid arthritis the first time to ensure clarity. Similarly, MS stands for multiple sclerosis, and CVA refers to cerebrovascular accident. Now, it's equally important to steer clear of abbreviations like DC, which can be misunderstood. Sometimes it means discharge, other times it might mean discontinue. To prevent any miscommunication, it's better to use plain language during handovers. Overall, the key takeaway here is to prioritize clarity and simplicity. Prefer plain language, especially in high-risk or complex situations, to make sure we're all on the same page and providing the safest, most effective care possible. Let's go through some common abbreviations you might encounter in cardiology and pulmonology. First up, ACS stands for acute coronary syndrome, which includes a range of urgent heart conditions like heart attacks. Next, HF refers to heart failure, a condition where the heart isn't pumping effectively. MI is myocardial infarction, or a heart attack, caused by blocked blood flow to the heart muscle. VT or SVT stands for ventricular tachycardia or supraventricular tachycardia, both types of abnormal rapid heart rhythms. PHT is pulmonary hypertension, which means high blood pressure in the lungs' arteries. BNP and NT-proBNP are biomarkers, brain natriuretic peptide and N-terminal proBNP, that help us assess heart failure severity. SpO2 versus PaO2 is about oxygen levels. SpO2 is the oxygen saturation measured by pulse oximetry, while PaO2 is the partial pressure of oxygen in arterial blood, giving us more detailed info about oxygenation status. Lastly, VSD stands for ventricular septal defect, a congenital heart defect involving a hole between the heart's ventricles. These abbreviations are essential tools for quick communication and understanding in clinical practice, especially when we're managing complex cardiorespiratory cases. Let's take a moment to review some common neuro and psych abbreviations that you might encounter in clinical practice. First, PNES stands for psychogenic non-epileptic seizures, which are episodes that resemble seizures but aren't caused by electrical disruptions in the brain. Moving on, CIS refers to complex involuntary seizures, a term used to describe certain types of seizure activity. PD is Parkinson's disease, a neurodegenerative disorder affecting movement and coordination. AD stands for Alzheimer's disease, the most common form of dementia. Lastly, ODOSOU are abbreviations related to eye medications. OD means oculus dexter or right eye, OS is oculus sinister or left eye, and OU stands for oculus uterc, meaning both eyes. However, it's important to avoid using OD when specifying dosing to prevent confusion. Understanding these abbreviations helps us communicate more effectively and ensures clarity in patient care. Let's go through some of the key abbreviations and concepts that are essential in our clinical assessments. First, GA stands for gestational age, which helps us determine how far along the pregnancy is. Then there's EDD, the estimated date of delivery, crucial for planning and monitoring. PV refers to the patient's presentation or vaginal examination findings. SROM or ARM indicates spontaneous or artificial rupture of membranes, important for assessing labor progress. IUGR or FGR points to intrauterine growth restriction or fetal growth restriction, which can impact fetal health. NVD is normal vaginal delivery, the ideal scenario in many cases. LMP, or last menstrual period, helps us estimate gestational age and fetal development. Moving to other vital assessments, UC stands for uterine contractions, which we monitor to understand labor patterns. TB is tuberculosis, relevant in certain patient histories. AKI indicates acute kidney injury, a critical condition we need to recognize early. DKA, diabetic ketoacidosis, is a serious complication in diabetic patients. TSH, T3, and T4 are thyroid function tests, essential for evaluating thyroid health. CRP and ESR are markers of inflammation, helping us identify infectious or inflammatory processes. C. diff refers to Clostridioides difficile infection, which can cause significant gastrointestinal issues. We also look at GFR and eGFR to assess kidney function, especially in patients with renal concerns. D-Obgyn/PEDS highlights the importance of collaboration across obstetrics, gynecology, and pediatrics. Finally, GI, renal, endocrine, and infectious disease specialists play vital roles in managing complex cases. All these components are interconnected in providing comprehensive patient care, and understanding them helps us make better clinical decisions throughout the course of pregnancy and beyond. Let's take a closer look at some of the common imaging views and techniques. First, we have AP and PA, which stand for anteroposterior and posteranterior views, respectively. These are standard frontal views, with AP typically used for chest and abdomen, and PA often for the chest to reduce heart magnification. Then, we have lateral and oblique views, which provide side and angled perspectives to give us a more complete understanding of the anatomy. Moving on, the planes coronal, sagittal, and axial are fundamental for orientation. The coronal plane divides the body into front and back, sagittal splits it into left and right, and axial or transverse cuts horizontally, giving us cross-sectional images. These planes help us visualize structures in different orientations. Decubitus positions, like side or purpose-specific positions, are also important because they can influence how fluid or air moves in the body during imaging. Contrast agents, which are sometimes used, help highlight specific structures, and knowing the right dose is crucial for safety and effectiveness. When comparing ultrasound, often abbreviated as US, to other imaging modalities, ultrasound is real-time and portable, while MRI offers detailed soft tissue contrast without radiation. Speaking of MRI, we also have MRI, MRA, and MRV, each tailored for different vascular and soft tissue assessments. Finally, understanding the various imaging planes and views is essential for accurate diagnosis. By combining different views and techniques, we can get a comprehensive picture of what's happening inside the body, which ultimately supports better patient care. Let's start by looking at troponin I versus troponin T. Both are key cardiac markers, but they have different clinical implications and testing nuances, so it's important to understand which one is being used in a given context. Next, we have LFT's components. These are liver function tests that include measurements like ALT, AST, ALP, bilirubin, and sometimes albumin. They help us assess liver health and identify possible hepatic injury or dysfunction. Moving on to AG-OB, or antigen and antibody testing. These are crucial for diagnosing infectious diseases, such as hepatitis or HIV. Recognizing the patterns of antigen and antibody presence can guide us towards specific infections or stages of disease. Then there's bands or left shift. An increase in band cells indicates a shift to the left, often reflecting a bacterial infection or an acute inflammatory response. It's a useful sign to identify ongoing infection. Next, C and S with site and time, culture and sensitivity testing, helps us identify the causative organism and determine the most effective antibiotic. And noting the site and timing of the sample collection ensures accurate interpretation. O and P stands for ova and parasites, which are important when we're evaluating for parasitic infections, especially in patients with relevant exposure history. Serum versus ABG bicarbonate. Serum bicarbonate is part of the metabolic panel, while ABG bicarbonate reflects the acid-base status directly in arterial blood. Both are useful, but serve slightly different purposes. The anion gap equation helps us assess for metabolic acidosis by calculating the difference between cations and anions in serum. Recognizing an elevated anion gap can point us toward causes like ketoacidosis or renal failure. PT and INR are measures of blood clotting. PT is the prothrombin time, and INR standardizes this measurement. They help us evaluate coagulation status, especially before procedures or in liver disease. Absolute counts refer to the specific counts of white blood cells, red blood cells, and platelets, which are fundamental in assessing overall hematologic health and detecting infections or bleeding issues. Finally, F laboratory abbreviations and result phrases, being familiar with common abbreviations and how results are phrased in reports, allows us to interpret lab data accurately and efficiently, ensuring we don't miss critical findings that impact patient care. By understanding these key components and their interconnections, we can better interpret lab results within the larger clinical picture, guiding our diagnosis and management effectively. When it comes to dosing, administration, and timing, especially in high-risk situations, there are some key points to keep in mind. First, it's important to avoid using certain abbreviations like U, IU, or MUG because they can be confusing or lead to dosing errors. Instead, always write out the full term and use clear units like milliliters when referring to volume. For example, say ml instead of abbreviations. You should also avoid abbreviations like OD, QD, QOD, or HS, which can be misinterpreted or misunderstood. Clear communication is crucial here, especially when managing medications that require precise dosing and timing. When administering medications, always use the term subcutaneous for injections and measure the dose in ml to keep things straightforward. Remember, in high-risk scenarios, every detail matters to ensure patient safety. By following these guidelines, we help minimize errors and ensure that medications are given safely and effectively, aligning with our overall goal of providing high-quality care. Let's take a closer look at some of the key surgical terms you'll encounter during procedures. First, resection refers to removing a specific segment or part of tissue or bone, often to eliminate disease or damaged areas. Revision surgeries are performed to correct or improve previous operations, which can be necessary if complications arise or if the initial results weren't satisfactory. Washout involves irrigating a space or cavity, typically to clear out infection, debris, or fluids. Drains are inserted to help remove excess fluids or blood postoperatively, reducing the risk of complications. Exploration means carefully examining the area to identify issues or assess the extent of disease or injury. Moving on, decompression is a technique used to relieve pressure on nerves or spinal structures, often crucial in neurological or musculoskeletal cases. Fusion involves joining two or more bones to stabilize a region, which is common in spinal surgeries. Lysis refers to breaking down scar tissue or adhesions that might be causing pain or restriction of movement. Stent placement is used to keep a vessel or duct open, ensuring proper flow of blood or fluids. Grafts are tissue transplants used to repair or replace damaged structures. Lastly, reduction is the process of realigning fractured bones or dislocated joints to restore normal anatomy. All of these terms are fundamental to understanding operative procedures, and they highlight the wide range of techniques surgeons use to treat complex conditions. Recognizing these terms helps us better understand the surgical approach and the goals behind each intervention. Let's take a closer look at some of the key specialty areas. In cardiology and respiratory, the unique challenges often involve managing complex comorbidities and ensuring accurate diagnosis despite overlapping symptoms. Moving to neurology and orthopedics, pitfalls can arise from subtle neurological signs or misinterpreting musculoskeletal issues, which highlights the importance of thorough assessment. For OB/GYN and GI/HPB, timing and understanding the nuances of presentation are critical, especially when symptoms can be similar to other conditions. When we consider renal, urology, endocrine, hematology-oncology, infectious diseases, and ophthalmology, each has its specific pitfalls, such as atypical presentations or diagnostic delays. Overall, being aware of these specialty-specific pitfalls helps us improve diagnosis, avoid errors, and deliver better patient care. Recognizing these common pitfalls is a vital part of our broader goal to enhance clinical accuracy across all fields. All right, let's clarify some common pitfalls related to administration, timing, and documentation. First, when we specify timeframes, it's important to write 1 week instead of using fractions like 152 to avoid confusion. Clear, straightforward language helps ensure everyone understands the timing expectations. Next, when discussing triggers, always use the terms right-sided or left-sided rather than just side. This precision helps prevent ambiguity, especially when making clinical decisions or documenting interventions. Finally, pay close attention to the potential pitfalls in administration, timing, and documentation. These can include errors in timing the administration, miscommunication about triggers, or incomplete documentation. Being thorough and precise helps ensure safe, effective care and smooth communication among the team. Remember, these details might seem small, but they play a crucial role in overall patient safety and treatment success. In the before scenario, the plan was to proceed with surgery for a cervical mass, which involved reviewing labs and starting heparin at 5,000 units every 12 hours, while discontinuing warfarin. Now, after the review, the plan is more specific. We're performing head and neck surgery for a left cervical level II lymph node mass. We also need to review coagulation studies, such as PT-INR and APTT, to assess the patient's bleeding risk. Instead of unfractionated heparin, we're starting low molecular weight heparin, UFH, at 5,000 units subcutaneously every 12 hours. And importantly, we'll discontinue warfarin before surgery to reduce bleeding risk. This updated plan highlights the importance of precise anticoagulation management tailored to the surgical context, ensuring patient safety while optimizing surgical outcomes. Now, let's look at some practical ways to embed these templates effectively into our workflow. First, we can incorporate them directly into EPR note types and discharge summaries, making sure they're easily accessible when documenting. Next, for areas with ambiguous anatomy, like distinguishing between cervical spine and cervix, we can use pick lists to streamline choices and reduce confusion. It's also important to auto-expand high-risk abbreviations on their first use, so everyone understands exactly what we're referring to and minimizes errors. Validation rules for units, roots, and laterality are crucial. They help ensure that the data entered is consistent and accurate across different entries. We can include prompt snippets for AI tools, highlighting the required fields to guide users effectively. And to support our junior staff and ASR users, having a quick reference list can be a real lifesaver, providing instant guidance and reducing unnecessary delays. All these implementation ideas are about integrating smart, user-friendly features into our systems to improve accuracy, efficiency, and safety. They tie into our overall goal of enhancing the quality of documentation and clinical decision-making through smarter tools. When documenting timelines, it's best to avoid using fractions like 1/52 weeks or 2/12 months outside of clinician-only contexts. Instead, it's clearer to write out the timeframes in weeks or months to avoid confusion. Also, when referring to medications, always use generic drug names and specify the full route of administration, such as subcutaneous, to ensure clarity and consistency. In obstetrics and gynecology, make sure to expand abbreviations on first use. For example, write out obstetrics and gynecology instead of obgyn. Additionally, when discussing radiology, explicitly state the view and modality used, like a transverse view on ultrasound, to provide precise information. For UK-specific notes, be mindful that some terminology or practices may differ, so tailor your documentation accordingly. Overall, these points help maintain clarity, precision, and consistency throughout our clinical documentation and communication. Let's start by understanding that making context fixes can significantly reduce most misreads. For example, paying attention to details like the site, specialty, intent, units, and timing helps ensure we're interpreting information correctly. It's also crucial to expand high-risk abbreviations and avoid using unsafe dosing shorthand, which can prevent dangerous errors before they happen. When documenting, always name the specific organ or system involved, as well as the modality, rather than making assumptions. This clarity improves communication and patient safety. Additionally, adopting templates, pick lists, and auto-expansion tools into your workflow can streamline documentation and reduce manual errors. These strategies help maintain consistency and accuracy in your notes. The key takeaways here are about being proactive with context, clarity, and workflow tools to minimize errors. Remember, precision and clarity in documentation are essential parts of delivering safe, effective care. Please pause to read the following tables referenced above. Thank you. Let's take a closer look at some of these terms that have multiple meanings depending on the context. Starting with cervical, this word can refer either to the cervical spine, which is the neck region, or the cervix, which is part of the female reproductive system. The key to understanding which meaning applies often depends on the specialty involved, the patient's age and sex, and whether we're talking about imaging studies or pelvic exams. Next, fundus is another versatile term. It can describe the uterine fundus in obstetrics and gynecology, the gastric fundus in gastroenterology, or the ocular fundus when we're examining the back of the eye. Again, context is everything. Knowing which specialty and which part of the body we're discussing helps clarify the meaning. Moving on to apex, this term is used across various fields. It might refer to the heart apex, the lung apex, the apex of the patella, or the tip of a tooth. When you hear apex, consider whether we're discussing an imaging region or the focus of a physical exam. Similarly, base can describe the bases of the lung or the heart, or the skull base. Recognizing the context, whether it's an imaging report or a neurological versus a cardiovascular focus, guides us to the correct interpretation. Now, cortex is another term with multiple applications. It can refer to the cerebral cortex in the brain, the renal cortex in the kidneys, the adrenal cortex, or the osseous cortex of bones. Knowing the organ or system involved and the imaging modality helps clarify which cortex is being discussed. Let's look at labial, which can mean the lips, the dental surface, or the vulvar labia. Distinguishing whether we're in a dental, ENT, or obgyn context is crucial for accurate understanding. Dorsal generally refers to the back, but it can also mean the back of the hand or the top of the foot. Always consider whether the discussion is about the hand, foot, or trunk to interpret this term correctly. Moving to ventral or anterior, these terms typically describe the front surface of the body or are used as imaging labels. Clarifying which body region is in question ensures correct interpretation. For palmar and plantar, These specify the surfaces of the hand and foot, respectively, and are important when discussing limb involvement or injuries. Medial and median are directional terms, but median can also refer to a specific structure like the median nerve. When these terms are used, it's helpful to consider whether they're indicating direction or nomming a particular structure. Finally, septum can refer to the nasal septum, the interatrial septum of the heart, the interventricular septum, or the uterine septum. Recognizing the context, whether ENT, cardiac, or gynecological, helps determine which septum is being discussed. And last but not least, valve can refer to cardiac valves, venous valves, or even the ileocecal valve. Again, understanding the system or organ involved allows us to interpret these terms correctly. So the key takeaway here is that many anatomical terms are polysemous. They have multiple meanings, and the context, including specialty, body region, and imaging modality, is essential for accurate understanding. Let's take a closer look at some polysemous anatomy terms and their directional cues. First up is sinus. This term can refer to the paranasal sinuses, dural venous sinuses, or the coronary sinus. The context is key here, whether we're discussing ENT issues, neurovascular concerns, or cardiac conditions. Next, antrum can mean the maxillary antrum in the nasal cavity or the gastric antrum in the stomach. Again, context helps us distinguish between ENT and gastrointestinal topics. Moving on to canal, which might refer to the auditory canal, the anal canal, the cervical canal, or the birth canal. Recognizing the organ or system involved guides us to the correct interpretation. Then we have hilum, which can describe the hilum of the lung, kidney, or spleen. When reviewing reports, noting the organ helps clarify which hilum is being referenced. The term neck can indicate a body region, like the neck of the femur or humerus, or just describe a part of a bone. If it's bony, nomming the specific bone provides clarity. Head similarly can refer to the head of the radius, femur, or the skull. Specifically nomming the bone keeps things precise. Root is used for structures like the tooth root or nerve root, distinguishing between dental and neuro or musculoskeletal contexts. Capsule appears in joint capsules, organ capsules, or medication capsules. Understanding whether we're discussing a procedure or pharmacology helps interpret the term correctly. Lobe can refer to lung lobes, liver lobes, thyroid lobes, or brain lobes, so specifying the organ is crucial. Next is ring or annulus, which might be the annulus fibrosus in intervertebral discs, the corneal ring in the eye, or a vascular ring around structures. Recognizing the structure involved is essential. The labrum appears in the shoulder, such as the glenoid labrum, or in the hip, like the acetabular labrum. Clarifying the joint helps avoid confusion. Finally, plantar and dorsiflexion refer to motion or surface orientation at a joint. For example, plantar flexion involves pointing the toes downward, while dorsiflexion raises the foot upward. Always specify the joint involved to keep the discussion precise. In summary, these terms are polysemous, meaning they have multiple meanings, and understanding the context, the organ, the system, or the structure involved is vital for accurate communication. Now let's look at some common medical terms and how their meanings can vary depending on the context. Starting with base, head, and shaft. These terms often refer to bone segments, but in everyday language they might just describe the part of an object. For example, when we say the base of the skull, we're talking about a specific bone structure. Next, the term cyst. This can mean different things depending on where it appears. We might hear about a Baker's cyst, which is related to the knee joint, an arachnoid cyst within the nervous system, or an ovarian cyst in the reproductive organs. So, context clues like the location help us understand what type of cyst we're dealing with. Moving on to nodule. This term is used across various specialties. For instance, a thyroid nodule refers to a lump in the thyroid gland, a pulmonary nodule is found in the lungs, and dermatologic nodules are skin lesions. Again, the site and even the imaging modality used can help clarify what kind of nodule we're talking about. Then we have mass, which often implies a tumor, but it can also mean a palpable swelling or an area with increased radiographic density. Knowing the modality, whether we're doing an ultrasound, CT, or MRI, guides us to interpret what the mass might be. Finally, lesion is a broad term that can refer to abnormalities in the skin, central nervous system, bones, or mucosal surfaces. The site and the imaging modality are key to understanding the nature of the lesion. Overall, these terms exemplify polysemous anatomy, the idea that the same word can have different meanings depending on the context, and highlight the importance of understanding directional and site-specific cues. Recognizing these nuances is crucial for accurate diagnosis and effective communication in medicine. Let's go through some common terms that can easily be confused and how to tell them apart. First up, we have the ileum, which is part of the small intestine and often confused with ilium, the pelvic bone. To distinguish between them, think about their location, GI tract versus skeletal structure. Next, perineal versus perineal. Perineal relates to the fibula, the outer part of the lower leg, while perineal refers to the area between the genitals and anus, the pelvic floor. Context here is key, limb versus pelvic region. Moving on, ureter and urethra. The ureter carries urine from the kidney to the bladder, so it's upper urinary tract, whereas the urethra is the tube through which urine exits the body, lower urinary tract. Then, malleolus versus malleus. The malleolus is the bony prominence on each side of the ankle, part of the skeletal system. The malleus, on the other hand, is one of the tiny bones in the middle ear, which is part of the ENT region. Similarly, scaphoid and navicular. The scaphoid is a carpal bone in the wrist, while the navicular is a tarsal bone in the foot. To specify which one, always clarify whether you're talking about the wrist or the foot. Next, trapezium versus trapezoid. Both are carpal bones, but in different locations. Be precise to avoid confusion. Radial versus radius. Radial is an adjective referring to the side of the forearm or radius bone itself. The bone is called the radius, so the structure versus the bone are distinguished by context. Tarsal versus carpal. Tarsal bones are in the foot, carpal bones are in the wrist. Again, specify limb to avoid mix-ups. Pubic versus pudendal. The pubic area refers to the pelvic bone, while pudendal relates to neurovascular structures or the perineum. Think about whether you're discussing the bony pelvis or nerves and vessels. Adductor versus abductor muscles. These describe actions, adducting or abducting limbs, and their names reflect that function. Varus versus valgus. These terms describe deformity directions at joints. Varus means bending inward, valgus outward. Recognize the joint involved to interpret these correctly. Pronation versus supination. Both describe rotational movements of the forearm and limb. Pronation turns the palm down, supination turns it up. Motion and limb position are your clues here. Finally, there's the detailed table of look-alike or sound-alike terms, or LASA. These are tricky because similar sounds or spellings can lead to confusion. Always double-check the context, clinical setting, anatomy, or region to ensure you're using the correct term. Understanding these distinctions is crucial, especially in communication and documentation, to prevent errors. Keep these cues in mind as a handy guide in your practice. Now, let's take a closer look at some common terms that can easily be confused or mistaken for others. First up is anteversion, which is often confused with retroversion. To keep these straight, remember that anteversion refers to the forward tilt, such as of the uterus or hip, and you can distinguish it by considering the angle units, degrees versus other measurements. Next, we have humerus, which is frequently misspelled as humerus. Just think of spell check to avoid that funny mistake. Moving on, median can be tricky because it's often confused with medial. But here, context matters. Median typically refers to a nerve or a middle line, while medial describes a position or direction. Then there's saphenous, which is sometimes mixed up with cephalic. To tell these apart, remember that the saphenous vein runs along the limb, whereas the cephalic vein is located more laterally. Now onto thoracic outlet, which can be confused with thoracic inlet. The key distinction is that thoracic outlet refers to a syndrome involving neurovascular compression, while thoracic inlet is simply an anatomical opening. Recognizing whether you're discussing pathology or anatomy helps clarify the term. Finally, we have a detailed table covering look-alike and sound-alike terms, or LASA words. These can be particularly tricky because they look or sound similar but have very different meanings. Being aware of these helps prevent miscommunication in clinical practice. Overall, mastering these distinctions enhances clarity and accuracy in our communication, especially when dealing with complex anatomy and terminology. Let's take a closer look at some clinical words that can have different meanings depending on the context. First, we have shock. This term can refer to circulatory shock, which is a critical drop in blood flow, or to electric shock, like when someone touches a live wire, and even psychological shock, such as trauma or distress. To figure out which type we're dealing with, we often look at vitals, lactate levels, or the underlying mechanism. Next is stroke. It can mean a cerebrovascular accident, which affects the brain, or heat stroke, caused by hyperthermia or even sunstroke. To differentiate these, we examine neurological signs versus signs of hyperthermia. Then we have seizure. This might be epileptic, febrile, or a psychogenic non-epileptic seizure, or PNES. Witnessed features and EEG findings are key to distinguishing these. Moving on to block, which could be an AV block in the heart's conduction system, a nerve block in anesthesia, or a bowel obstruction. Here, understanding the system involved and relevant tests helps clarify the meaning. Positive can mean a test result that's positive, indicating presence of something, or positive affect, meaning a good mood. Context, like the test name or mood, guides interpretation. Similarly, negative can refer to a negative test result or negative symptoms in psychiatry. Again, the domain helps determine which meaning applies. Benign could refer to a non-malignant tumor or a benign course of disease, indicating a good prognosis. Pathology versus prognosis is the key distinction. Induction might relate to labor induction, anesthesia induction, or chemotherapy induction, depending on the specialty involved. Reduction can mean fracture reduction, dose reduction, or hernia reduction. It's important to distinguish whether we're talking about a procedure or a pharmacological adjustment. Fixation might refer to internal fixation of bones or psychological fixation, again depending on the context or specialty. Infiltrate can be seen on imaging, like pulmonary infiltrates, or refer to local anesthetic infiltration during procedures. Finally, culture can mean microbiological culture, used to identify pathogens, or organizational culture in a hospital setting. Understanding these words' different meanings is vital for clear communication, especially in multidisciplinary teams. Always consider the context to interpret these terms accurately. Now, let's take a closer look at some clinical words that can have different meanings depending on the context. On this slide, we have a table that highlights a few key terms. First up is left shift. In some cases, this term refers to neutrophilia with bands, which is a laboratory finding indicating an infection or inflammation. It's often an ops term, meaning it's used in specific clinical contexts. To clarify this meaning, we look at labs as a disambiguation cue. Next, we have failure. This can mean organ failure, like the heart or kidneys failing, or it can refer to a failure to respond to treatment. To specify which type of failure we're talking about, it's important to include the organ involved or the specific criterion used for diagnosis. The main point here is that many clinical words can be ambiguous, and understanding the context, like labs or specific clinical criteria, is essential to interpret them correctly. This is a critical part of clear communication in medicine, helping us avoid confusion and ensure everyone is on the same page. Let's take a closer look at some common abbreviations and their meanings, as well as best practices for their use. First up is RA. It can stand for rheumatoid arthritis, right atrium, or room air. It's important to remember that the context determines which meaning is correct, whether we're discussing disease, anatomy, or oxygen therapy. Next, we have AS, which might mean aortic stenosis or ankylosing spondylitis. Again, the field or specialty guides us, cardiology versus rheumatology. Moving on to MS, where the abbreviation could refer to multiple sclerosis, mitral stenosis, or morphine sulfate. This highlights the importance of being precise, using the full term or clarifying to avoid confusion. MR is another example. It can mean mitral regurgitation or, more obsolete, a cognitive label. Precision here is key to ensure clear communication. AR might represent aortic regurgitation or allergic rhinitis, shifting between cardiology and ENT considerations. Similarly, AI can stand for aortic insufficiency or artificial intelligence, again depending on the context, medical versus technological discussions. Then we have PA, which could mean postero-anterior chest X-ray, pulmonary artery, or physician associate. Recognizing the context, imaging, anatomy, or role helps us use the abbreviation appropriately. PE might be pulmonary embolism, physical exam, or pleural effusion, each relevant in different clinical scenarios. For CP, the possibilities include chest pain or cerebral palsy, indicating either acute or chronic neuro conditions. DC stands for discharge or discontinue. Always write it out fully in documentation to avoid ambiguity. Finally, SOB is shortness of breath. It's best to spell it out to ensure clarity, especially in critical communication. And then, there are high-risk abbreviations in general. The key takeaway is always to consider the context carefully and opt for clarity to ensure patient safety and effective communication. Now, let's look at some common high-risk abbreviations that can cause confusion if we're not careful. On this slide, we see a table that highlights a few examples. For instance, PT can stand for physiotherapy, patient, or prothrombin time, depending on the context. It's crucial to understand whether we're talking about a role versus a lab test to avoid mix-ups. Similarly, CVA can mean stroke or costovertebral angle. When we see CVA in a neurological exam, we refer to stroke, but in physical exam documentation, it might refer to the area near the kidneys. The key takeaway here is that many abbreviations have multiple meanings, so we need to be aware of the context to interpret them correctly. Using these abbreviations carelessly can lead to miscommunication, so always clarify or write out the full term when in doubt. This slide reminds us to be cautious with high-risk abbreviations, especially in documentation and communication, to ensure patient safety and clear understanding. Let's take a closer look at some of these high-risk abbreviations related to cardiology and respiratory care. First, ACS stands for acute coronary syndrome, which is a term we often see in the context of heart attacks and unstable angina. It's important to note that when we see ACS, it refers specifically to the disease process, not the organization or a group. Next, HF can mean heart failure, which is a clinical syndrome where the heart's ability to pump blood is compromised. Sometimes, HF also refers to high-flow oxygen therapy, which is a different concept entirely, used to improve oxygenation in critically ill patients. So, context really matters here. Now, MI stands for myocardial infarction, commonly known as a heart attack, but it can also mean mitral insufficiency in a different setting. So, understanding the context helps us interpret these abbreviations correctly. Moving on, VT and SVT refer to types of abnormal heart rhythms seen on ECGs, ventricular tachycardia and supraventricular tachycardia. These are critical to recognize because they can be life-threatening. PHT is pulmonary hypertension, a condition involving increased blood pressure in the lungs, arteries, versus phenytoin, a medication used for seizures. Again, context is key to avoid confusion. When we see BNP or NT-proBNP, These are cardiac peptides measured in blood tests. They help us assess heart failure severity and guide management, crucial in both diagnosis and monitoring. SpO2 versus PaO2 highlights different oxygen measurement modalities. SpO2, or pulse oximetry, gives us a non-invasive estimate of oxygen saturation, while PaO2 is measured via arterial blood gases, providing a more precise assessment but requiring a blood sample. Finally, VSD refers to ventricular septal defect, a congenital heart defect involving a hole between the ventricles. Recognizing these abbreviations and their meanings is vital for clear communication, especially in high-pressure situations involving the heart and lungs. Overall, understanding these abbreviations helps us interpret clinical information accurately and respond effectively in patient care. Let's take a closer look at some high-risk abbreviations in neurology and psychiatry. First up, we have PNES, which stands for psychogenic non-epileptic seizures. It's important to spell this out clearly because it can sometimes be mistaken for epileptic seizures, but the underlying cause is psychological rather than neurological. Next, we see CIS, meaning clinically isolated syndrome or carcinoma in situ. Depending on the context, this abbreviation can relate to a neurological condition or a type of early-stage cancer. So, understanding the specialty or the setting helps clarify which meaning is intended. Moving on to PD, which can stand for Parkinson's disease, personality disorder, or peritoneal dialysis. Again, the context is key here, whether we're discussing movement disorders, mental health, or renal treatment, to interpret this abbreviation correctly. Then there's AD, which might refer to Alzheimer's disease, atopic dermatitis, or even right ear, also known as oris dextra. Remember, in clinical documentation, clarity is crucial, so always specify what AD refers to in your notes. Now for OD, OS, and OU. These relate to the eyes. OD is the right eye, OS the left eye, and OU both eyes. Also, avoid using OD alone when specifying dosing. Instead, write out the full instruction to prevent confusion, especially with once-daily dosing. Finally, I want to highlight that some abbreviations, especially those used in neurology and psychiatry, are high risk. Misinterpreting them can lead to errors, so always double-check and clarify when in doubt. Recognizing these abbreviations and their multiple meanings helps us communicate more effectively and safely in our practice. Let's go through some of the common abbreviations you'll encounter in obstetrics and pediatrics, especially those marked as high risk. First, GA stands for gestational age, but it can also mean general anesthetic depending on the context. So, it's important to clarify whether we're discussing obstetrics or perioperative settings. Next, EDD refers to the estimated date of delivery, and it's crucial to specify this clearly to avoid confusion with brand names or other terms. When you see PV, it typically means per vagina, often related to pulse volume. But in examinations, it can also refer to vascular assessments, so context matters. Now, SROM and ARM both relate to rupture of membranes. SROM stands for spontaneous rupture of membranes, and ARM is artificial rupture of membranes. It's best to write these in uppercase and expand on them to avoid misunderstandings. Moving on, IUGR or FGR refers to growth restriction. Here, it's recommended to use the preferred term FGR to be precise. NVD means normal vaginal delivery, but it can also stand for nausea, vomiting, and diarrhea, so always pay attention to the context. Lastly, LMP, or last menstrual period, is often used to estimate gestational age, but again, context is key to understanding its exact application. Remember, these abbreviations are frequently used in high-risk scenarios in obgyn and pediatrics, so being familiar with their meanings and proper usage helps ensure clear communication and patient safety. Let's go through some of these high-risk abbreviations that are commonly encountered in GI, renal, endocrine, and infectious disease contexts. First, UC stands for ulcerative colitis, which is a chronic inflammatory bowel disease. but it can also refer to urine culture when we're talking about infections. It's important to distinguish whether we're testing for the disease itself or doing a urine culture to identify a urinary tract infection. Next, TB can mean tuberculosis, a serious infectious disease, but in labs, it also refers to total bilirubin, which helps us assess liver function. So always clarify whether we're discussing infectious disease or lab values. Moving on, AKI stands for acute kidney injury, a condition that nephrologists manage closely, so it's within the specialty domain. Then there's DKA, or diabetic ketoacidosis, which involves abnormal glucose and ketone levels, crucial to recognize in diabetic patients. When we see TSH, T3, and T4, we're looking at thyroid function tests, and knowing the analytes and units helps us interpret whether the thyroid is underactive or overactive. CRP and ESR are markers of inflammation. Understanding whether they were measured by specific methods and their units helps gauge the degree of inflammation in conditions like infections or autoimmune diseases. C. diff, or Clostridioides difficile, is a bacterial infection that we confirm through lab testing, often stool assays. GFR and eGFR refer to the glomerular filtration rate, which estimates kidney function, and it's calculated using specific equations. Knowing which equation is used can impact interpretation. And finally, these abbreviations are considered high risk because they often involve complex diagnoses across GI, renal, endocrine, or infectious diseases. Recognizing these terms and understanding their context is key for accurate diagnosis and management. Let's take a closer look at some key terms and abbreviations we encounter in imaging. First, AP and PA. These refer to the antero-posterior and postero-anterior views, respectively. When you see PA, think of a chest X-ray taken from back to front, and it's useful to specify CXR-PA view to avoid confusion. PA can also stand for pulmonary artery or physician associate, so context is important. Next, lateral versus oblique views. These terms relate to the view versus the location. For example, instead of just saying lateral, it's clearer to say lateral view of the knee to specify the perspective. Moving on to planes, coronal, sagittal, and axial, they describe the planes of imaging. Remember, coronal is also used to refer to dental crowns, so specifying the modality plus the plane clarifies what you're discussing. Decubitus refers to the patient's position during imaging, indicating whether the patient is lying on their side and which side is down, left or right, and the purpose, such as detecting free fluid or air. Contrast, meanwhile, can mean different things. Imaging contrast agents or signals in MRI. Always specify the agent and dose for clarity. Ultrasound, often abbreviated as US, can sometimes be confused with the country, so it's best to write ultrasound or USS to avoid ambiguity. Lastly, MRI, MRA, and MRV. These are different but related. MRI refers to the imaging sequence, while MRA and MRV specify angiography or venography techniques. Be sure to specify which sequence you're talking about to convey the correct information. Understanding these terms and their nuances helps ensure clear communication in radiology, which is essential for accurate diagnosis and effective patient management. All right, let's dive into some key laboratory terminology and abbreviations that can often cause confusion. On this slide, we have a table outlining terms, their potential ambiguities, and how to clarify them. Starting with troponin, or trop. The main issue here is distinguishing between troponin I and troponin T, as well as understanding the assay sensitivity. So, always specify which type of troponin you're referring to and include the brand or assay details along with the units used. Next, we have LFTs or liver function tests. The term can be a bit of an umbrella term since it doesn't refer to a single function but a panel of tests. To be clear, list out the individual analytes like ALT, AST, bilirubin, and so forth. Moving on to AG-OB, which stands for antigen or antibody tests. The key point here is to specify what the test is targeting. Are we detecting the pathogen's antigen or the patient's antibody response? Then there's the term bands or left shift, which refers to immature neutrophils. But in the lab domain, this can be confused with other concepts, so clarify if you're talking about the presence of immature neutrophils as an indicator of infection or inflammation. For culture and sensitivity, or C&S, the abbreviation is straightforward, but the site of culture and timing are often unclear. Always specify where the sample was taken from and when. O and P, or ova and parasites, can be confusing because it might be interpreted as outpatient procedures. Clarify whether you're referring to lab testing for parasites or the outpatient setting. HCO3- bicarbonate can come from serum or arterial blood gas measurements. Make sure to specify the source and the analyzer used, as results can vary. The anion gap is calculated differently depending on the equation used, especially with or without potassium. Always specify which formula you're employing, particularly if K+ is included or not. PT, INR, and APTT are coagulation tests, but they can be mistaken for physiotherapy terms. To avoid confusion, say coagulation, PT, INR, and APTT to make it clear you're discussing blood clotting assessments. Regarding WBC, neutrophils, and lymphocytes, these can be relative percentages or absolute counts. To be precise, always report the absolute counts along with units for clarity. Lastly, the table includes many other abbreviations and result phrases, emphasizing the importance of precise communication in the lab domain to avoid misinterpretation. In summary, always specify the context, source, and units when discussing lab tests. Clear, detailed descriptions help ensure accurate understanding and appropriate clinical decisions. Let's walk through some common abbreviations that can cause confusion and how to handle them safely. Starting with U, which can look like 0 or 10U, meaning 10 units. To avoid errors, always write out units. Next, IU, which can be mistaken for IV or 10. Instead, write international units. Moving on to MUG, where the Greek letter mu can be misread as M, leading to milligrams instead of micrograms. Here, it's best to write micrograms explicitly. Now for OD and QD, these abbreviations stand for once daily, but they can also be mistaken for right eye, especially with OD. So to prevent mistakes, write once daily. Then we have QOD, which means every other day, but sometimes gets confused with daily dosing. Clarify by writing every other day. Next is HS, which can mean bedtime or half strength, so to avoid ambiguity, specify at bedtime. For SC or SQ, which stand for subcutaneous, some might misread it as 5Q, which is a different dosing instruction. To be clear, write subcutaneous. The abbreviation CC looks like 0, but it's better to write ml to specify milliliters clearly. Lastly, Latin abbreviations like NOCT, main, or STAT are often not understood by AI or other systems. Instead, use plain English terms like at night, in the morning, or immediately. The key takeaway here is that these abbreviations, especially in dosing, administration, and timing, are high risk. Always aim for clarity by using plain language to ensure safety and prevent errors. Let's take a closer look at some common surgical terms that can be quite ambiguous without proper clarification. First, we have resection. This term can refer to either a partial or total removal of an organ or a specific segment of an organ. To avoid confusion, it's important to specify the extent or the particular segment involved. Next is revision. This term can mean different things depending on the context, either an implant revision or a revision of a surgical plan. Clarifying whether we're talking about the procedure itself or the documentation helps prevent misunderstandings. Moving on, washout can refer to different processes, such as joint washout or a pharmacologic washout period. Clearly stating the context ensures everyone understands what kind of washout we're discussing. Then there's drain. This could mean a surgical drain, an actual device, or the act of draining fluid or material. Specifying whether we're referring to the device or the action helps clarify the intent. Exploration also has multiple meanings. It can be a surgical exploratory procedure or a diagnostic test to investigate a condition. Being explicit about which type of exploration we mean is crucial. Similarly, decompression can involve different regions, such as spinal, compartment, or abdominal decompression. Mentioning the specific region ensures clarity. Fusion is another term that varies across specialties. It can refer to spinal fusion, arthrodesis, or cellular fusion. Clarifying the type of fusion and its purpose is essential. Lysis can refer to adhesiolysis or thrombolysis, so specifying the target, whether it's adhesions or blood clots, is necessary. Stent may be vascular, biliary, ureteric, or airway stents, depending on the organ involved. Clearly indicating the organ helps prevent ambiguity. When it comes to graft, this can mean a bypass graft, skin graft, or tendon graft, so specifying the type and site is important. Reduction might involve fractures or hernias, and including the procedure name along with the site helps make the context clear. Overall, these terms highlight the importance of precise disambiguation in surgical documentation. By specifying the context, region, target, or type, we ensure clear communication and accurate understanding of the procedures involved. Let's go through some of the specialty-specific abbreviations and terms that often come up in our daily practice. Starting with cardiology, you'll frequently see abbreviations like AS, AR, MS, MR, TR, and PR, which stand for aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation, tricuspid regurgitation, and pulmonary regurgitation. AF refers to atrial fibrillation, while SVT and VT are supraventricular tachycardia and ventricular tachycardia. In the context of acute coronary syndrome, or ACS, we often differentiate between SDEMI and NSDEMI. CABG stands for coronary artery bypass grafting, and PCI is percutaneous coronary intervention. Sometimes you'll see DC cardioversion versus discontinue, which relates to rhythm management. Also, PA pressure refers to pulmonary artery pressure, and LV and RV are left and right ventricles. LA and RA are left and right atria. When we mention inferior in ECGs, it usually refers to leads II, III, and AVF. Moving to respiratory, abbreviations like PE stand for pulmonary embolism, and COPD is chronic obstructive pulmonary disease. Be aware that CO can refer to carbon monoxide or cardiac output, depending on the context. VC, FEV1, and FVC are vital lung function tests, vital capacity, forced expiratory volume in 1 second, and forced vital capacity. VQ means ventilation perfusion scan, or ratio, and HFNC is high-flow nasal cannula oxygen therapy. In neurology, CIS is clinically isolated syndrome, MS is multiple sclerosis, and PD is Parkinson's disease. GBS stands for Guillain-Barré syndrome, ALS or MND is amyotrophic lateral sclerosis or motor neuron disease. NPH refers to normal pressure hydrocephalus, which is different from NPH insulin, so context matters. LP is lumbar puncture. Orthopedics often involves abbreviations like OA for osteoarthritis and RA for rheumatoid arthritis. THA and TKA are total hip and knee arthroplasty. ORIF and CRIF refer to open and closed reduction and internal fixation. PIP, DIP, and MCP are finger joint names, proximal, distal interphalangeal, and metacarpophalangeal joints. UCL and RCL are ulnar and radial collateral ligaments. ACL, PCL, MCL, and LCL are the major knee ligaments, and PFJ refers to the pedalofemoral joint. Fracture types of the femoral neck are also common. In obgyn, PV stands for per vaginam, and SROM arm are spontaneous rupture of membranes and artificial rupture of membranes. IOL is induction of labor, but be cautious. Sometimes IOL can mean intraocular lens, so the context is key. GA is gestational age, LMP is last menstrual period, and EDD or EDC are estimated due dates or estimated date of confinement. PPH is postpartum hemorrhage, and LSCS refers to lower segment cesarean section. For GI and HPB, UC is ulcerative colitis, and CD is Crohn's disease. ERCP and EUS are endoscopic procedures, endoscopic retrograde cholangiopancreatography, and endoscopic ultrasound. MRCP is magnetic resonance cholangiopancreatography. HCC is hepatocellular carcinoma, and PTC can refer to percutaneous transhepatic cholangiography or cholangiocarcinoma, depending on the context. In renal and urology, AKI is acute kidney injury, CKD is chronic kidney disease, and ESRD is end-stage renal disease. HD and PD are hemodialysis and peritoneal dialysis. UTI is urinary tract infection, and URTI is upper respiratory tract infection, just to keep things clear. PCNL refers to percutaneous nephrolithotomy, and TURP is transurethral resection of the prostate. Endocrinology includes DM1 and DM2 for type 1 and type 2 diabetes. DKA and HHS are diabetic ketoacidosis and hyperosmolar hyperglycemic state. TSH, T3, and T4 are thyroid function tests. Addison's disease and Cushing's syndrome are adrenal disorders, while SIADH is syndrome of inappropriate antidiuretic hormone secretion. In HemOnc, you'll see abbreviations like ALL, AML, CLL, and CML, types of leukemia. TLS is tumor lysis syndrome, DIC is disseminated intravascular coagulation, and ITP-TTP refer to immune thrombocytopenic purpura and thrombotic thrombocytopenic purpura. FOLFOX and FOLFIRI are chemotherapy regimens, and CIS is cisplatin. In infectious diseases, TB is tuberculosis, and HIV is human immunodeficiency virus. HBsAg and HBag are hepatitis B markers. PCR or NAAT are molecular diagnostic tests. MIC is minimum inhibitory concentration, and MRSA, MSSA are methicillin-resistant and methicillin-sensitive Staphylococcus aureus. Ophthalmology abbreviations include OD, OS, and OU for right, left, and both eyes, and sometimes OD alone refers to dozing. PVD is posterior vitreous detachment, and peripheral vascular disease also comes up often. Overall, these abbreviations are common, but they can be tricky because different specialties might use the same abbreviation for different things. Always pay attention to the context to interpret them correctly. Let's go through some key pitfalls and how to practice safer wording during admin, time, and documentation. First, take a look at the term 152 in the UK. That's shorthand for 1 week. But the problem is, AI or anyone else might misread that as a fraction or something else. So instead, it's much clearer to just write out 1 week. That way, there's no ambiguity. Next, when you see follow-up PRN, it often refers to a vague trigger. But what does that trigger actually mean? To avoid confusion, it's best to state explicit criteria. For example, instead of just saying PRN as needed, specify exactly what symptoms or conditions warrant the medication. Now, the terms right-left can be tricky. They might refer to direction, but they can also be mistaken for correctness or past tense. To be clear, use right-sided or left-sided when talking about locations or sides of the body. That reduces any potential for misinterpretation. Overall, the goal here is to use precise, unambiguous language in documentation and communication. Clear wording helps improve patient safety and ensures everyone is on the same page. Keep these points in mind as part of your safer practice approach during admin and documentation. All right, let's walk through this key example to highlight some important concepts. Originally, the plan was to perform surgery for a cervical mass, and the initial steps included reviewing labs and starting heparin at 5,000 units every 12 hours, while discontinuing warfarin. Now, after clarification, we see that the surgery is specifically for a left cervical level II lymph node mass. The focus shifts to reviewing coagulation status by checking PT-INR and APTT to ensure safety before proceeding. We also specify starting unfractionated heparin at 5,000 units subcutaneously every 12 hours. This is important because it provides a manageable anticoagulation strategy around the time of surgery. And of course, Discontinuing warfarin is crucial since it has a longer half-life and needs to be stopped to reduce bleeding risk. Overall, this example emphasizes the importance of clarifying patient specifics and tailoring anticoagulation management to ensure safe surgical planning. It highlights how precise communication and understanding are vital in balancing bleeding and clotting risks in these scenarios.